as was mentioned earlier. You have in the packet, in addition to the age changes, the types, the middle level plans, both over 138, and then again with the effect very positively by private option. With private option, we have 90% of plans in that silver level, so that you see very few, about 6% bronze and about 4% gold, so about 10% other than silver, and many of those silvers have cost sharing reductions in addition to their premium assistance. The average premiums that are non-subsidized are reflected on the bottom of page 4 of your report. So you can see that those average across all regions, across all ages, both all enrollees, again, prior to subsidy, range from $465 per month on gold plans to $134 on the catastrophic plans. We have been specifically asked to update the piece on cancellations. So the next chart you see on page 5 shows that 64% are showing current, 27% are due the first payment. Remember, the plan is not enforced until the first month's payment, premium payment is made. That 27% is pretty good, given that we had 33% come in the last month, so it's showing people are paying that. The grace period reflects those who have made their first month's payment, but then would be behind after that, and that averages to 0%. It's 0.004, but a very small amount of grace period. The 9% are not all canceled for non-payment. There could be some number of that for non-payment, but these could be people who decided to change plans as they were allowed to do during open enrollment, so they had to disenroll from a plan or cancel the plan to enroll in different, or they may have been able to become employed and get employer-sponsored coverage, or there are a number of reasons for those cancellations, but included in that could be those who had a first month non-payment. Going on, we have had continued high activity. If you looked across open enrollment period, our resource center received about 125 calls a day. We continue to license all types of assisters as required, and the greatest number by far remains the licensed issuers and producers. The brokers and producers. They are approaching 1,500 now. On the guides, we have had activity where since open enrollment until April 7th, the guide organizations reported assisting with encounters for enrollment assistance, 97,565, so close to 100,000 encounters, 36,000 outreach activities attended by 480,000 approximately individuals. So as we entered those contracts, we had a 10% withhold on all the guide organizations for performance. They negotiated a performance measurement, so there were metrics between the individual organization and the department, which was based on the population of uninsured, the number of guides they had, and projected outreach activities. And most of the organizations met all their goals. 17 of the 26 eligible will get their full 10% withhold. Only one organization will get none of that withhold. They were very small, guide organization with one guide and very specific target population. And the others have varying amounts. All of the guide organization contracts will end at the end of June, per your direction. We have taken a look at producer assistance, and this will continue to vary. But looking at the overall marketplace, private option, non-private option, about 18,000 individuals, or about 12% overall, had a licensed agent or broker assist with that enrollment. That was 21% over 138% and about 8% under. It's interesting how those demographics go. It's reported in this report for the previous time that the highest enrollment by agents and brokers was in the southeast region and the lowest in the northwest. The newest data from April 21st, which is not reflected in your report, this came in Monday afternoon, but we were able to find that now the northwest region still has the lowest, but the south central region now has the highest percent of enrollment by agents and brokers, and that's 25%, and at the lowest in northwest it's 19%. On the plan management side, it's kind of hard to believe it's already time to do this again. The new bulletin with the requirements for the 2015 year plans for certification was issued on April 11th. The plans will be submitting for approval, their plans for the 15 year, May 1st to June 15th. One significant change is that the essential health benefit package now does include the mandatory offerings of hearing aids and TMJ. Because it was allowed to go into the mandatory or to the essential health benefits, that will be at no cost to the state. It will be paid by Medicaid or by the tax credits.
If I could elaborate on that, those were mandated benefits that came out of the last session. Those came out.
No, sir. Because they were before 11, we were able to put in EHBs. Now, there was one last session, craniofacial, that will be a new mandatory benefit.
So what you have to guard against on the mandatory benefits is they're not in the essential benefits as approved by Health and Human Services. The state has to pay. And so we'll send up a flyer on the afternoon session and put this such stuff, with what they're presenting. But that could be a real problem, and you got to remember that the coverage is very broad under the essential benefits. It's broader than it's ever been for your constituents. So, but if we start adding and we have to send the bill to the state, I don't think y'all are going to, you'd have to appropriate money, is what you'd have to do.
Probably important for you all, we had reported last time we were here that we had pending for approval our latest federal funding cooperative agreement, which we had submitted in February, was pending. And that was what we had decreased from a $10.8 million preliminary ask to $1.45 million after the prohibition and outreach education promoting enrollment. After that, though this funding was approved on April 14th, the department withdrew that funding application. So we are not accepting that last funding, and we just felt that it was better to repurpose, which we're allowed to do, some of the funding that we already had from previous cooperative agreements.
We will be asking for appropriations on our existing efforts and contracts. It won't be education, it won't be outreach. So it's a good time to say, Cindy, that we have reduced that back, and when we come back to you all for authorization, it's not for any projects in those areas.
The Health Insurance Marketplace Board, the new state-based marketplace, is moving along. The board has been meeting regularly. As you know, they have hired an executive director, Cheryl Smith. She gets here on May 19th. We are definitely committed to working with her for a smooth transition for when the state elects to go with a state-based partnership. Now, neither that board nor the department plans to ask for May federal funding. So the next ask will be by the Marketplace Board in August. We continue working on the evaluation plan. It could be that some of you are contacted by the College of Public Health. They are interviewing multiple stakeholders, so certainly we told them legislators would be an interested body, so you may hear from them. And we are working with our rate review division with ACI, with others on the Developing All-Payer Claims Database. So that kind of finalizes our prepared remarks and report to you, and we are available to answer questions.
All right, thank you. Senator Cooper, you're recognized for a question.
Did you hear the question I asked earlier about the competition?
Yes.
Okay, would you address that, please?
And I'd like to say congratulations.
Thank you.
That's the first question you've asked me. I know it won't be the last. So, yes, one thing I think I'm really excited about as far as competition. You know, these companies that came in, we negotiated with them on their territories. Everybody wanted Central Arkansas, and everybody wanted Northwest Arkansas. So we negotiated to take some of these more underserved areas. And so what has happened through actually competition, where we only had National Blue Cross and the domestic Blue Cross in some areas, all the companies are going to go into all areas next go around. So in essence, what you have is two more competitors in those underserved areas. And so I'm real proud of that. I think it speaks well for what you all have done in the private option. These companies that would want to expand in the state and bring more competition to your various areas. So that's really, really good news. We got this open date for the next 6 or 8 weeks, and we hope other companies will come in. We have indications that we may get another multi-state company. That's like the National Blue Cross. If they come in, they'll be in every territory. And so we're hoping they'll come to give us a 5th competitive market for your constituents. What you have to realize in this earlier testimony, these studies, these actuarial studies are projections. And as time goes by and the companies see actual claims history, that should give them courage to come in. You know, one of the largest companies in the nation is going to wait, for a couple of years. And they're waiting to look at the hard numbers. So if our numbers hold up, the actuarial firm, and it is more competitive, it's more profitable than those numbers, we should see more companies come in, and we should see more competitive rates. So I think the best signal I have for you all is the fact that these companies are doing business in our state with our constituents, have seen the need to expand in these other territories. That's pretty good confirmation in my view.
Is there not any, is there a relationship between doctors or providers not taking or being reluctant to take Medicaid and what you might perceive as the available competition margin out there that's available?
Yes. From the onset, the insurance companies, by and large, have paid a better percent of reimbursement than our Medicaid system, under the old system. Now, how that develops as time goes by, because there's a lot more money that is going to be in the mix, that gives insurance companies more buying power to the providers. And so that's a competitive tool right there. But right now, I think most providers would say it's better for them under the insured private option basis. Hospitals and, your local providers.
Thank you, Madam Chair.
All right, thank you.
Senator, I just was going to comment that many of the physicians that might not have accepted Medicaid because under private option, it's a private insurance plan and a higher reimbursement are accepting now. So many of the physicians are accepting consumers they did not have before, if that's part of what you were asking.
All right, thank you. Chairman Link, you're recognized.
Thank you. Probably, this is a question that's probably several months too early, but let's try it anyway, and then maybe in July or so, we'll start looking at these numbers, and you can get a pretty good idea. With the over 138%, we hit 17.5% of the target. And then the open enrollment will start again in November through into December, whatever those numbers were. Any idea of how much that would increase? Do you think some people are going to see that this, any idea?
Well, It will run till the end of, or mid-February this first year, and then you're right, it'll be December kind of in subsequent years unless it changes again. I think the biggest jump is likely to be in the 16 plan year. We would hope we would see more coming in the 15 plan year. But what will happen on the penalties, as they go up, by 3 years out, they're gonna be 2.5% of a household income, or $695 per adult, and half of that for each 3 children, and it's gonna be kind of what you pay and not have insurance. They will get the smaller penalty next spring when they file taxes, and that'll be after open enrollment. So people who are gonna really know that it's important to do this because it's the law and financially will be looking to enroll in plan year 16 in open enrollment. What could change that is what our consumers understand and are able to know. So the more people know, and communities can share, providers, hospitals, however that's to be now, of the opportunities and the value for not only that individual, but the whole community. I think we'll see more. We had hoped to get 116,000 in the individual market if things had gone great. So we're maybe going to be lucky to get 45,000. So there's room. I don't have a firm projection, but I don't think we'll get near that 116 next year.
Another fact you may have read, or maybe you didn't, but the people who are uninsured in Arkansas, 90% of them or more are eligible for some type of tax credit. You know, these are people over 138 that are working people, but when that sliding scale, if you know, it goes up to $90,000 plus for family four. So in our state, we're a low-income state. That really encompasses 90% of our population. And you know, as time goes by, they'll realize they get the tax credits, and if our markets are competitive, which we're certainly going to do everything we can do to make them competitive, you know, that's going to be our answer for a lot of your constituents downstream, I believe.
Very good, thank you, Madam Chair.
Thank you. Let me just ask a question. Did I hear you say 90% of Arkansans would be eligible for a subsidy?
90% of the people who are not insured, you know, we say 500,000, a lot of times it's probably more. And so, yeah, those are people in 400% poverty below. And that's 90% of those people will be eligible for a tax credit. And that's not talking about your expanded, you know, private option population. So when you see the rate, the insurance rate, and off of that comes a tax credit based on sliding scale of income. So,
and one other question, and I don't know if this comes under something that you can do when it has, when the issue is a private insurance company, but as I heard today, that the private rates for the private option clients would then generate private rates for reimbursements, which we have been told in the past would be higher than the Medicaid rate. But if that is not true, do you have any authority to jump in and say that that's what I thought?
no, ma'am, Madam Chair, your insurance commissioner, whoever he or she is, they don't have any standing in those contractual relationships between the provider and an insurance company.
That's what.
The legislature is controlling that in the future, of course, but as it stands now.
And the reason I asked that was right after the private option passed, several of us were under the impression that the rates would be higher. And then we had one insurance company that did a 15% cut to specialists across the board. And I think they decided maybe that wasn't a good idea, but there was, I think it was 10% for every physician. And so I have a hard time thinking that the private insurance rates will be the rates that are generated from taking care of the private option people. I hope I'm wrong, but that's kind of a speculation on my point at this time. All right, Representative Meeks, you're recognized for a question.
Thank you, Madam Chair, I appreciate it, and Ms. Crone, I appreciate your response to the breakdown on the payment status. I know that we've already kind of discussed this on email, but I want to kind of get out in the open, the cancel that you have there, amounts to 4,019 folks. I'm wondering why you've included the cancellations in the enrollment figures, and is Arkansas, that you're aware of, is Arkansas the only state that is doing this, or are other states also including their cancel policy in their enrollment figures?
Excuse me, Representative, thank you. The enrollment figures we give are matching the federal enrollment figures, which is a consumer who has selected a health plan. So we're talking about total enrollments. Now, this graph you're talking about is payment status, I believe.
Yeah, the payment status one.
So we're kind of talking about two different things here. So we have enrollment definition that matches the federal marketplace enrollment definition, and probably what most states are using, which is enrolled in health plan. Separate than that, I know the federal marketplace has not been able to say how many plans are canceled, and so that data has not come out from federal. I don't know about other states to answer that part. Because Arkansas could not get the county level data we needed from the feds, and we needed some things like demographics before even age started coming out from the feds, we began to request that the carriers report to us every 2 weeks their enrollment data and some basic demographics, and included in those was payment status. So that is how we were able to report this. Now, it's not clean cut that you can subtract the 9% from those enrolled, because some of these are enrolled. They might be enrolled in another company's plan. They would be counted. Say one company had somebody who enrolled and canceled, then that's a wash. They wouldn't report them in the enrollment data, so you track it by one person. But if that person canceled with one company and enrolled in another company, the way we have the data coming in, we don't have individual identifying information, we have blinded information by individual. It's possible that that person could be counted in this 9% and somewhere else. But the 9% would also include people who then are covered because they canceled a plan, which they were allowed to do during open enrollment, and chose a different plan. It could be that they canceled because they got employer-sponsored coverage.
Right.
It could be they canceled because of non-payment. So we can't say the whole 9% is non-payment.
Right, well, again, my concern is just accurate numbers, because what we're really worried about is not necessarily folks who are enrolled, but folks who are actually have an insurance policy where they can actually go to the doctor. And I'm concerned that, and I know it's not necessarily you guys are controlling it, maybe Washington D.C., but we hear this 8 million figure, hey, 8 million people are actually enrolled where they're signed up. But when you actually break down the folks who are actually have an insurance card and actually go to the doctor, that number shrinks very dramatically. And I'm very concerned in this aspect by what you're telling me is that you could actually have a double count of a person, meaning they've enrolled,
Very little possibility. I mean, it'd be few numbers.
Right, again, but again, it's just about accurate numbers to gauge how well we're doing, because, you know, the goal here of everybody is to have access, to be able to go to a doctor and to be able to get the health coverage that you need. And it seems to me like what we're doing is we're not meeting that goal. And then we're trying to inflate numbers by saying, hey, we've enrolled 8 million people, we've enrolled 44,000 folks. And the fact is right now we only have 28,000 folks who are actually current, meaning that they can actually go to a doctor under under our health insurance marketplace. And I understand 27 may or may not pay, hopefully they will, to be able to get the coverage that they need. But, you know, at this point, only 28,586 or so Arkansans are able to actually go to the doctor and get the health care that they need under that health insurance.
Well, I understand your concern and your question, so we can't answer it any more specifically now. As time goes by, we'll be able to get more definitive numbers. this is what we can give you today.
Okay, and my second question is, the budget to run your office, because it was supposed to be off of the fees through the health insurance marketplace that was supposed to kind of, it was, you know, we talked about it several months ago. This whole health insurance marketplace was supposed to be self-sustaining. Based on these current numbers here, if your office had to be self-sustaining on these enrollments, would it be able to?
Well, there would be enough premium tax generated to do it very easily. However, it's got to go through the legislative process and be appropriated through y'all's process. There's a 2.5% premium tax on all these new premiums, and I think some projections that don't hold me to this. I probably read it in the paper, but they were $30 million a year. That would come off the premium tax. That goes through the legislative process, and sure, we can operate ours on considerably less than that.
But right now, you're still operating off of federal grants?
Yes, we are.
No state money? I know the private option money, we basically set that aside for future years, but this particular, the 44, 28,000 or whatever that's paying their premiums, where is that tax going? Is that going into your?
Premium tax, and then we distribute it back to the DFMA, and it goes through the.
So it's going right now, the 28,586, that premium tax right now is just going back into general revenue to be used, however.
It'll be up to the next year when you all make the budget, it'll be there.
And about how much would you generate off of?
We generate totally with our licensure fees and everything. It's about $200 million a year.
But I'm talking about just off the people on the exchange, off this premium tax. Have you done figures based on these numbers to find out how much of a premium tax you're gonna generate for your office? Trying to get a number, because we need to set aside this money. Let's go ahead and get it set aside somehow.
I do not have it with me. I think I reported some of it last month, and we have done that. We have tracked it based on our current enrollment, which last time I did that, I think was about a month ago, and then also on projected future enrollment. So I can't tell you exactly what those amounts would be, but around, it would exceed what it would take to run the state marketplace in our view. And I can get you those numbers. They change every day with enrollment. So it's,
Right, I
actually, when
understand.
they come in, it's a per member per month and the average cost, and then 2.5%. So we can get that to you.
If you would just disclose, maybe based on these April 21st numbers, that'd be
Sure,
perfect.
I'll do that.
Before the Affordable Care Act, our revenue was about $200 million a year. The Department of Insurance operates on $12 million a year. The rest of it goes through the budget process. Actually, off the top comes police and fire pensions off the top of that. And then there's money for the state workers' comp program. And the rest, and some goes to Medicaid, and the rest goes through the budget process. So that's the present numbers before this project, $200 million.
And then I got one
Well,
final.
I tell you what, let me put you on the bottom of the list, Representative Meeks, and we're going to take Senator Chesterfield to recognize.
Thank you, Madam Chair. I do not want any reason to put Mr. Meeks at the bottom of the list. I did want to know, however, when was the last time that you advertised the program to entice people to come in here and sign up?
The last time we paid and initiated any advertising was before September 30th. That was the date that you all did not renew the contract for Outreach Ed. There were some existing contracts for the Southeast Conference Athletics and an Olympic package, so there were some ads run that had been paid for and purchased before September 30th. But our last advertising, stopped September 30th.
So we're talking about the 9th month, and here we are in almost the 5th month of this year without advertising, and people are still signing up.
We had a lot of people, agents, brokers, people on the ground, navigators, guides, assisting with getting the information out this enrollment period. And the feds, I mean, every time we would see something, the phones would light up. Every time something went out, whether it was ours or not, the phones would ring.
And I don't have a problem with that, as you obviously know. What I'm trying to get to is this: as we move forward, do you think you have in place the system that will allow us to sustain getting individuals enrolled as they need to be, because we will have a new deadline, and then there are some that we don't have deadlines at all? I'm just trying to figure out sustainability.
No, there's going to be some private efforts out there to promote the hospitals. The special language allowed the hospitals to do promotion, to sign people up in medical school. But I think there's nonprofits that are going to pick up on this and everything. But as far as the state and the department, we're not permitted to do any education.
I know, but I was just trying to find out the other source.
I think you'll see there'll be efforts from nonprofits there to get the word out.
Thank you.
All right, thank you. Representative Hammer, and then Representative Hutchinson, and we will go back to Representative Meeks. You recognize Representative Hammer.
Thank you. One of the questions I had was about the percentage. I was looking at one of the graphs. When it comes to the number of folks that are signed up in rural Arkansas areas versus the number of the folks that are signed up in metro type areas of Arkansas, I think I heard one of y'all say about the percentage of population was greater in the rural areas than it was, say, in the metro areas. Did I understand that right?
The percent enrolled of those eligible over 138 was higher in the rural areas, yes, sir.
Okay. And as far as people signing up in the rural areas, the more underserved areas, do we have any idea of how many uninsured still exist in the county, by county? I heard the number 500,000 mentioned a while ago. Is there any way to know a definitive number as far as how many uninsured are by county?
Not today, but that certainly will be a goal. We, at this point, could just do simple math. That would not account for somebody possibly who changed status, though much of what we have in the way of information is that these are people that were uninsured becoming insured. But I can't say that's 100% across the board. So do not have that today. That'll be something that's being tracked. I know there are polls asking about prior and current status.
Okay. How do we know then there's 500,000 as a point of reference? That's what I'm trying to grasp is, if we're going to base projections, how do we know, how do we correlate the two?
Prior to open enrollment, the 510,000 adults, or those 19 to 64, was from Kaiser Family Health projections. They did state projections, and that 510 came from there. We had a 550, 585 looking at all people, but we've done pretty well with our children. We've done pretty well with our over 65, so it was that 19 to 64-year-old that really had the gap. And the projections of our 2011 study had a higher number, but as it changed over time, the most recent going into this open enrollment was about 510,000 19 to 64-year-olds based on Kaiser Family Health.
Okay, and although it doesn't really change the end result, I'm just curious in the percentages that are on the pie charts, is there a place that you can point to as to the number of people that had policies before all this began and their policies got canceled really through no fault of their own, or are they just, there's not a way to break out that percentage, is there? Or is there?
But you recall this, that early on, I extended the right to renew for 1 year, and then the feds picked it up later, and we extended through 2016. So people can keep their policy until that point in time. So there shouldn't be much fallout there, people want to keep their old policies, they're certainly permitted to do so in this state.
And it was extended to
Yes.
2016, we got another year extension, right?
Yes.
Okay.
That, in a way, is going to be somewhat helpful for a company looking at our state, because there's a population there of people who have insurance, who've left it where they've had it. But in 2016, things will change to the national level. Those people are going to be buying on the Arkansas Exchange, probably by then, on the federal exchange. So that's a latent group of prospects for a company.
Do we know how many that is? Is there any way to project that number? Because wouldn't they end up going into the marketplace after 2016 if it doesn't renew?
I can't, I'm not to check, I'd be afraid to guess at it, and we may have something we can furnish for you.
Last couple of questions have to do with the issue of advertising. Now, the private insurance companies, because I've seen their ads on TV, they're still advertising.
That's right.
And they've got a number on there, if I remember right, for people to go to, which if they get to that number that's being advertised on TV, they're gonna get all the help they need to get enrolled. Is that correct?
Well, it's supposed to work that way.
Okay. Okay. And then the individuals that are currently enrolled now, when it comes time for them to have to renew, do they get notifications through the mail, just like I get at the place I work, that, hey, it's time for you to renew, and you got time?
It's the same as privatized, and that's going to be the same method, and they have to follow the same notification laws that we have on the books to protect the consumer.
So if they're a responsible participant in the program, they're gonna get that renewal, and just like anybody else that's out there with any other type of insurance, they have a burden of responsibility to do what they have to do. So we shouldn't really see a decrease in numbers if people are gonna be responsible and respond to that. Is that correct?
That's true. They'll have the same rights as everybody does. They'll get a notice, and they'll have so many days to pay it. They'll get a reminder, and then they'll get a cancellation notice.
Okay, all right, thank you.
Thank you. All right, next is Representative Hutchinson. You're recognized.
Thank you, Madam Chair. Briefly, y'all stated a while ago that the state exchange was, y'all were trying to go in this office, coming office, or next office?
That's, that there's a legislative organized committee that's working on that. As Cynthia said, hired a director who's quite qualified. And so, my guess, the students who could be here would be 16.
Okay.
They may make it more feasible to wait till later, that's their decision.
Okay, and a while ago, one of y'all mentioned about the hearing aids for like being, would be basically free, or something like that. Would that, but those that are 65 years and older that have like Medicare supplement, that don't include them, right?
No, and the marketplace is for those under 65. And what it means is it's a mandatory benefit now. It was a mandatory offering. It's in the essential health benefit, which means that for those who are subsidy eligible, whether it's full private option, Medicaid, whether it is a sliding scale subsidy, the federal government will pay their portion of that benefit. So if the consumer has some cost sharing, they would pay their cost sharing part.
Okay. Y'all would admit that I've tried to dig in this as much as anybody, right? And y'all said something a while ago that really just kind of slapped me in the face there. And there's not a dumb question to me, but I got to ask this. I kind of feel funny for the first time ever asking a question. I mean, anyway, but I thought I should know. The state marketplace, the Federal Partnership Exchange, does it just deal with the PO?
No. The marketplace deals with everybody under 400% of the federal poverty level. If they're up to 138%, they're private option eligible. They can apply through the state or through the federal marketplace, which would send them to the state to enroll. So the marketplace only, which, as your I think, terming it would be for those over 138. Only those to 400 could get subsidies. Anybody can shop there, no matter what their income. But those under 138, except for a few, the existing Medicaid eligibles, or medically frail would be private option eligible.
Okay, I understand that, but so the marketplace board is responsible for all the way up to 400. Gotcha. All right, and one of
They'll
the
have to
Ma'am?
continue to coordinate with DHS on private option. But because private option is buying private insurance plans, and because they'll be working with the insurance department on those private plans and how it works in the marketplace, I would say yes, they work on both.
And a while ago, Representative Meeks mentioned, talking about the premium tax and everything. It's gonna have to go to the state, to the marketplace board for it to sustain itself, correct?
Certainly, it will have to be funded by some source. Now, at this point in time, people who are buying insurance from the National Exchange, there's a fee on their premium. This is for 3.5%. And so we've always said that we think that we can lower that in Arkansas. And we feel very sure.
Maybe not even pay it.
So we would be, or we could use the premium tax if the budget committee and you all decide that that's a good use of that, and I would say it would be, so we'll hopefully get rid of that 3.5% when it comes back to our state, and you pick up the difference, through the other revenue. Now, that'll be decisions to be made by the legislature and the marketplace board.
And there's talk about the minimum wage increase, that's gonna put a dent in everything.
That's out of my area there.
Thank you, Madam
All right, thank you. Last question, Representative Meeks. And I will remind you that we have one more item agenda. It's almost 4 o'clock.
And I hope that it's just a fairly simple question, but I'm hearing news reports from around the nation that after this open enrollment period is completely shut off, that the carriers are not selling individual insurance policies because of the pre-existing condition clause. They're afraid that people are going to wait and sign up. So they're either making it very difficult or they're not selling individual premiums after this date until the open enrollment period hits in November. Do you know, or are you aware of any insurance carriers here in Arkansas who are doing that?
Not at this point in time, I'm not aware of that.
If you happen to hear of any, please, I would like to know that, because again, it affects everything that we.
Sure.
And going forward, I can comfort you in that starting with next year's plan year, if a carrier offers a policy inside the marketplace, they must offer the same benefits at the same price outside.
So
You're there for the whole year.
So just say you were over 400%, not eligible for, you just want to buy it direct from an insurance company, they have to offer the same product inside or outside.
Or if you want to buy it, like say June 1st, you're like, oops, I missed it, whatever, and come back in June 1st and say, oh, I want a policy now.
Yes, because remember, the bulk of the people are coming to open enrollment. There are special enrollment periods. So there will be times all year that people, I turned 26 and I got off my parents' policy. Now it's time I can get on a policy in special enrollment. Or
To clarify, I'm not talking about going through the marketplace exchange. I'm talking about a special enrollment period, because there are folks who, for whatever reason, they just decide they didn't want to. Maybe they got a little extra money now, they want to purchase a policy.
Yes, because those plans must remain in the marketplace year-round. And the company must have an identical plan at an identical price outside the marketplace. And there's nothing that says they can stop that at certain months outside of open enrollment.
Okay, it's because I'm hearing in other states that they're kind of shutting that down because of the pre-existing condition, but anyway. Okay.
We'll keep an eye on that. I think a good example of those options is a member of the legislature, once, say, if you serve your term, you're not going to run again, the enrollment period is over, you're on state insurance, it opens it up. That's a change of life issue, so you can step right in and get coverage. That's important. Protect.
Thank you, Madam Chair.
All right, report. I really think we've learned a lot, and we'll look forward to the next time.
Yeah. Are we excused for tomorrow?
As far as I know,
Okay. I'll have somebody here, but
all right,
these people are hard working, I need to keep working on there. But we'll have someone here if y'all need anything, come to us.
that sounds good.
Thank you very much.
Appreciate that. Senator Chesterfield, did you have a comment?
You have a preliminary agenda for tomorrow, and is it possible for this report G to be postponed until tomorrow?
Just a minute, let me look at tomorrow's agenda. Why don't we go ahead with our next item, Senator Chesterfield, while we get an agenda for tomorrow. All right. Mr. Seeley, you are recognized for the last item on the agenda. So I believe you are taking Jody Jones's place today. We're talking about the Medicaid verification system.
Yes, ma'am, thank you. I'll try to be quick. 4 seconds for Jonas. We talked about this before, both in this committee and like on it, joint budget before. Just want to give you an update on the system because it's such an important piece of what we do. As you all know, we do eligibility for hundreds of thousands of people, and we're actually working on a system that's built on a 30-year-old framework, an old legacy system. And we, in 2010, began to look at really trying to put a new system in place. In 2012, we actually did an RFP and chose a vendor. We're now well into putting that new system in place. The good news is we are getting 90/10 federal funding for it, for this project. And what it does, it's going to allow us to improve our eligibility. It's going to allow us to improve the validation and verification that we do, our integrity, our data security. And it's the system, kind of the core system, that will allow people, before they really had to come to our county office for most of what they did, they will now be able to do a lot of it online. It frankly allows us to use our employees much more effectively than we did because we serve hundreds of thousands more people than we used to with the same employees. I just want to let you know where the first part of that is putting the Medicaid system in place. That's now, the core of that now is in place. We'll be working to improve that and then move to the SNAP benefits, the food stamp, and gradually add child care and other pieces. And next year, we hope to retire that old legacy system. So we'll just have a much more streamlined, much more user-friendly, frankly, a system that has a lot more data integrity. This is about a $50 million system. And again, we're about halfway through implementation of it, so it's a big deal. And one of the things that's come up recently is, as we move away from the development work, where we're really using our vendor and what we call stack augmentation, where we're bringing specialists, we are now moving to use more support from DIS. Well, they will use regular state employee positions. I think they've asked for 15 or 18 of those. That makes sense because state employees and regular positions over time are much less expensive than the contractors. So we're kind of moving into that maintenance and operation phase on much of Medicaid, and we're continuing to implement the other pieces. So that's, in brief, is where we are in the system.
All right, thank you. We have one question, Representative Hammer.
Real quick, is this a system that's going to deal like with billing code procedures when it comes to payment to physicians and other aspects of those who?
No, sir. I should have made that distinction because people do put them together. We have the MMIS system, the Medicaid Management Information System. That does really all the payment and runs the Medicaid program itself, including the part you're talking about. This is the part that makes people eligible for all of our programs. So it's different than MMIS. MMIS, actually, that's in procurement, and I think in the next 2 or 3 weeks, we'll probably announce a winner on MMIS.
Okay, and so the doctors and providers are going to be on that side, not on this side
That's right.
we're talking about.
That's right.
This is people
almost
side.
exclusively client focused.
That's right. Thank you, Madam Chair.
All right, thank you. Senator Key, you're recognized for a question.
Okay, thank you, Madam Chair. It's not really a question, I just want to acknowledge this. Mr. Seelig mentioned the issue about DIS, and this was a subject that came up in personnel, and I'd asked personnel to defer that at the time so we could get more information, and Mr. Seelig and his staff can come and update this committee. so that there'd be broader knowledge of the request from DIS and why they were asking. It was 16 is what had been approved from OPM to meet the needs of this ongoing system. Thank you for bringing that information to us today. And as far as I'm concerned, this is what we needed to have happen so we can move that forward next month in person. Good thinking.
All right, thank you. I appreciate that report, and like Senator Key, I think it was imperative that the Health Committee understand what was going on, and if there are any questions.
Yes. I want to mention one other thing, just for the committee. On Monday, we will have a meeting in our office on the ADHD episode. We have the results from attention deficit hyperactivity disorder. That'll probably be about a 2-hour meeting. People are welcome to attend. I actually have several results here that I can share now in probably 30 seconds or not. But I want to make people aware that that will be available. You're all welcome if you want to attend.
I have a great committee here, and I really appreciate the fact that they have stayed to the end. And if you promise it's 30 seconds, we'll let you just hit the high points.
Here's what it is. In the first year of the ADHD episode, we saw very good results. The average cost per episode fell by 29% for people with ADHD. And the care that people are getting is more closely aligned with what our physician group and doctors said is appropriate care. So that's good to know. Providers indicate that they are coding more accurately, whereas before they were coding a whole lot of people, just ADHD, primarily kids. They're now giving more complex coding, which we believe, at least in many of the cases, is more appropriate. And finally, it's helped surface for us some issues that we have to deal with. We have contacted 400 doctors and said, you've got people getting stimulants who don't appear to have a psychiatric diagnosis. And so we're contacting them and saying, there's some problem wrong with the data. If not, perhaps these children should not be getting psychiatric drugs, stimulants, if in fact they don't have a behavioral health diagnosis. So, it's a complicated episode, but in general, we're very pleased that it seems to be moving us in the right direction.
Well, that is a good report, so I'm looking forward to that meeting on Monday. All right, committee, do not forget about the dinner tonight at Pulaski Tech. Representative Broadway is over on the end, and if you would like to make a comment or two about what's going on tonight.
Got to be smart enough to work with microphone, so thank you. Yes, I just apologize that I was late for the meeting, Madam Chair, and appreciate you telling the committee about it. Tonight, transportation is going to be provided at 6 o'clock in the tunnel. The dinner actually starts around 6:30. There will be a cooking competition with some of our members and chefs at Pulaski Tech. About 7:20, we will actually be seated for dinner. The dinner is going to be delightful, and I really hope that you all can come. Know that there are students that are going to be serving us. They're going to be very excited about our attendance. The folks at Pulaski Tech are very excited about showcasing the program, and I think you all will really benefit from it. And so I'm very hopeful that as many of you as can come out there. I know the weather is bad, and I know there's lots going on, but I would truly appreciate your support from the people at Pulaski Tech. Thanks so much.
All right, thank you. And members of the committee, unless there's any other business, we are adjourned.
Going to the dinner. It's over.